I would like to thank AMP and Dr. Mustafa for letting me present this presentation today. The topic of my presentation today is different types of infrainguinal calcification, how to visualize them and how to treat them. Why the calcium is so important? We know that the calcium is known for its ability to compromise performance of our endovascular procedures. It can lead to dissections, embolizations, unable to dilate or expand the stent, leading to poor failure into the procedures. This was very elegantly presented by Dr. Fanelli, who showed that as the calcium burden increases, there is a significantly drop in primary patency and increase in luminal loss, even with the drug-coated balloons. There are certain risk factors or identification factors showing which patients have high calcification. Age definitely is, as we get older, there's increased incidence of calcified vessels, smoking, diabetes, and especially the chronic kidney disease leads to higher, very calcific vessels. There are different ways of identifying the calcium. This is one of the criteria for angiographically identifying how much calcium we had, which is not the best. We can see that it starts from focal, which is less than 180 degrees and less than 1/2 of the length of the lesion, all the way down to the very severely calcific vessels, which has more than 180 degree and 1/2 to the total length of this lesion. We can actually identify very nicely using different invasive tools, intravascular ultrasound, OCT, and actually also extravascular ultrasound, which gives you an exact location and amount of the calcification in the vessel. So when we look at the calcium, we have to see where exactly is the calcium. Is it in the intima? Is it the media, adventitia? So like in this case, we can see the vessel, all three vessels can be seen. Intravascular ultrasound shows that this is in the luminal part, which is 360 degrees. Now, this is the same sort of angiographic appearance, but when you look at the intravascular ultrasound, interestingly, this is an adventitial calcification with a very soft plaque. That leads to how do we really treat calcium effectively to have a good outcomes and a good results at the end of the procedure. We know that balloon angioplasty and stenting are not the ideal initial step. Directional atherectomies or other atherectomies has been shown to be very effective, leading orbital atherectomy, rotational atherectomy, and laser atherectomy. Shockwave lithotripsy has shown to be very effective in cracking those calcified vessels to have a very nice balloon expansion subsequently, and then obviously surgically removal of the calcified area. Let me give you some examples. This is a patient who has a very calcific vessel, and when we did and has a CTO, intravascular ultrasound interestingly shows that most of this calcium is adventitial. This led to the decision to use directional atherectomy, removing the plaque followed by drug-coated balloon angioplasty with very good results. This is another example. Again, all the tibial vessels can be seen without angiogram. This is angiography. You can see calcification. But in this case, you can see there's a luminal, severe 360 degree calcification. Here, directional atherectomy is gonna have a tough time. So orbital atherectomy was utilized with followed by balloon angioplasty, low pressure, leading to very good result with no dissection. This is one of the cases I like to show a patient with severe calcification, severe claudication, resting pain, unable to cross antegrade retrograde access was obtained, and subsequently I was able to get through to the occlusion. It was followed by orbital atherectomy and then followed by balloon angioplasty. These are the final results. So in conclusion, calcified vessels continue to be challenged for interventional procedures. but proper identification of the calcium location by invasive diagnostic tools and subsequently utilizing appropriate interventional tools can lead to a very successful outcome with minimal complications. Thank you.